It's been a great day, and we're going to start up our final session, and all I have to say is next up, Hardball with Rumsfeld and Masoudi.
So, hey Fred, what you doing?
You know, I'm kind of stressing out. I got to give this talk about appropriateness.
You have to give a talk on appropriateness?
Yeah, pretty much.
When?
Pretty soon.
Oh.
Yeah.
Yeah, well, you sure know how to have fun.
Yeah. You know what the thing is, John, is what I'm really thinking about is that appropriateness, I think, is very, very important, but I think it's often misunderstood.
All right, well, I got a little time. I could help you out with that, maybe. You know, one thing, Fred, when you're trying to figure something out, one good thing is sometimes to start with what the opposite of that is. So in this case, you know, maybe we should just start with what's completely inappropriate.
Yeah, I suppose we could do that, John. Sometimes you might, do that and lose your job.
Oh.
Yeah.
Right. Well, you know, but we'll provide appropriate warning for it, don't you think? I think we should.
John,
okay,
John, please stop.
So when I think of wildly
stop,
inappropriate
stop.
behavior, I can only think of one thing.
Oh, John. Let me see. I don't even recognize those people, and I'm adjusting my trifocals here.
You
who
don't recognize them?
No.
You're wearing trifocals?
Well, I mean, that's not,
What do you
that's
like,
any of your business.
What do you like, Ben Franklin?
Could be. Yeah.
The fact that you're wearing trifocals may be why you don't recognize these people.
Oh, okay. You know, though, John, when I think about what would be really appropriate right now,
yeah.
In contrast to Jason Bieber and that woman, whoever that was, I think a latte would really fit in well right now. Oh, thank you.
Well, thank you. Fred?
Yeah.
Seriously, a latte? You could have asked for anything?
Yeah.
And you asked for a latte?
Heck yeah, that's really appropriate.
So two things.
Yeah.
First of all, I got 2 words for you. Adult beverage.
Okay.
Keep that in mind. And second of all, do you really think you drinking caffeine this time of day is a good idea? I mean, wasn't there that incident?
Okay, that happened one time. And there was no conviction involved.
Okay. So
and so I think I'm okay.
Okay, so what are we talking about again?
I was trying to talk about appropriateness of medical care, really, is what I'm focusing on for this talk.
Oh, okay, appropriateness in medical care. So by that, you must mean the appropriate use criteria and all the complexity there.
You know, I think that complexity is important, and I know that there was some discussion about this earlier today at one of the CATH PCI breakouts, but that's not really where I think we should start. I think we should start, as Simon Sinek recommends in his book, that before we think about what we're doing and how we're doing it, we really need to think about the why. So I think we need to start with a why, about why we're thinking about and focusing on appropriateness.
Okay, so start with the motivation for things. So
yeah,
let
that's
me
a good
ask
place
you,
to start.
is this the why?
Well, John, I like a Beamer as much as the next guy. But the bottom line is, that's really not the why. The why is because we're focusing on appropriate health care that's effective and is based on the best available scientific evidence. Health care where we expect that the clinical benefits are going to outweigh any of the potential negative consequences of that intervention.
Okay, so I agree with that, but let me ask you this. Isn't that really what doctors are trained to do? I mean, if you're board certified, if you're a board certified physician, can't you just go ahead and make those decisions for patients?
John, we're not in the 19th century anymore. We're in the 21st century, newsflash. So, what we're talking about here is medical professionalism and the professionalism of an entire team, the physicians, the nurses, and other clinicians that are involved in patient care. The ABIM, the American Board of Internal Medicine, which oversees physician certification, has a great definition of professionalism. And it's important to recognize that a lot about appropriateness is integrated into this very definition of professionalism. They say that professionalism is the basis of medicine's contract with society. It demands placing the interests of patients above those of the physicians. Furthermore, it says that physicians must be dedicated to continuous improvement in the quality of healthcare and to minimize overuse of healthcare resources. and that we must actively participate in the application of quality measures to assess routinely the performance of healthcare delivery. And you know, these are principles, again, laid out by the ABIM for physicians, but I think they apply to the entire care team.
So I think this is a fantastic definition of professionalism, which should drive most of what we do. But I can't help thinking that there's something else. I mean, professionalism is awesome.
Totally.
But I think there might be one other thing that needs to be discussed.
Oh, money, right. Well, that is an important issue, but it's not exactly what you think maybe, like the nice red Beamer. It's the issue of global healthcare costs. It turns out that we've been hearing for a long time that things are unsustainable, and healthcare costs continue to grow incrementally over time. You know, we're right now spending about 16% of GDP on healthcare, about $1 out of every $8 or so. But the projections are that we'll be spending $1 out of every $2 in the entire economy on healthcare. Wow. And you and I can both acknowledge that that's nothing that our grandchildren and great-grandchildren, or in your case, your children, I guess, can be facing in 2082.
Okay, so what do we do about it?
Well, I think what we need to do is focus on unintended variation. And there are smart people around the world, like Don Berwick, one of the pioneers of quality, who says that unintended variation is stealing healthcare blind. The IOM estimates that maybe $200 billion a year is spent on wasted healthcare. So this is an area of focus, is this unwanted variation in care.
Okay, so, you know, I think this might help me, Fred, if we tag this to a specific therapy. So let's talk about angioplasty.
Sure.
Let's talk about PCI. Now, to me, the indications for PCI are pretty straightforward. You either have an acute case or you have an elective case in which you're treating angina, for example, despite medical therapy. So if the indications for angioplasty are pretty straightforward, is there much variation?
Turns out, yes, there is, John. If you look at the Medicare data that has been developed by Dartmouth that you see in this map here, where low areas of variation, where we're talking about maybe 4 per 1,000 Medicare beneficiaries getting PCI in the light zones, and as many as 40 Medicare beneficiaries getting PCIs per 1,000 in the dark zones, there's more than a 10-fold variation in the extent to which PCI is used in the Medicare population, even after you account for age, gender, and race. So there's no way that patient characteristics are accounting for this kind of variation. This is the kind of unintended variation that Berwick is talking about, in particular with respect to PCI.
Wow, okay. But you can't tell me that PCI has got to be, it can't be any more variable than, say, bypass surgery or for sure things like low back pain, right?
Yeah, I hate to tell you, John, but you're wrong again. If you look at the variation in use, this is colectomy on the left side, a variety of other procedures in the middle, including hip replacement, bypass surgery. If you look on the far right, that is PCI. It's kind of a mystery because the labels are missing, but you would know that that's PCI, and I'll tell you that that's the most variable procedure in that whole group of procedures, ranging from colectomy to hip replacement to bypass surgery.
Okay, so I'm with you. PCI is variable. It's more variable, actually, than other common medical procedures. But are you telling me, I believe that interventional cardiologists and patients understand why they receive angioplasty, certainly in the acute setting, but even in the elective setting, don't they know what PCI does?
Oh, John. It turns out, no again, I'm sorry, you're like, oh, for whatever. But, you know, it turns out that if you ask interventional cardiologists and referring cardiologists, in this very important study from the Annals of Internal Medicine, what you can see is that an important minority of interventional cardiologists and referring cardiologists actually have the belief that elective PCI reduces mortality and prevents the risk of heart attack.
Which it doesn't.
Which it does not. And then if you look at patients, the vast majority of patients believe that they're going into an elective PCI, getting it because it's going to prevent a heart attack or prolong their life. Now, in fairness, it may be that patients are on the Google and they're searching around and finding a bunch of misinformation. But the fact of the matter is that I think this reflects our failure to let patients know about what PCI really can and can't do for them.
All right, well, you know, Fred, it might just be that this latte isn't really doing it for me and not enough caffeine, but I feel like all of this is swirling around and it gets complex. I mean, is this something we really need to do?
You know, John, I can tell you I must have gotten both of the caffeines in our lattes because it's really kicking in for me now. Because the bottom line is, this is important stuff. The right objective for healthcare, John, is to increase value for patients, which means increasing quality or decreasing cost or both. We need to deliver more value. I mean, it's just as clear as can be. I mean, we're talking about appropriately delivering the right care to the right patient at the right time. Dude, it's like mom and apple pie. Don't you understand? It's like the flag waving over us. This is what the founding fathers wanted for us.
Beautiful for spacious skies, for amber waves of grain, for purple mountain majesties above the fruited plain. America, America, God shed his grace on thee and crown thy good with brotherhood from sea to shining sea.
Woo! Marianne Elma, NCDRs, Marianne Elma. Hey, Fred,
Yeah,
do you think you overdid that just a skosh there?
yeah. Could have been. You know, that was a lot of energy. You know, time right now, what I could really use is a little apple pie.
Oh.
Oh, that's terrific. Yeah. Thank you.
Seriously, did you learn nothing from the first time?
What do you mean?
When you asked for something?
What?
Adult beverage?
Oh, right.
Yeah.
But I'm thinking this could be caffeinated.
That's pretty much all we need, Fred. All right, so I think you've convinced me of the why. The medical professionalism, the variation and the need to have value and the need to have patient-centered care. I assume those are all the reasons that we should measure appropriateness, correct?
Yeah, it is. Hang on. There's more.
What?
There's more. There's
what
more.
else?
Turns out that if we don't do it, someone else will.
Ah, well, what do you mean by that, Fred?
Do you want a call from Dr. Legal?
Dr. Legal. Yeah, that's subtle. I'm just glad he has a toll-free number.
It is pretty handy.
That seems useful.
You know, John, joking aside, you know, appropriateness is serious business. I'm sure you're familiar with these headlines that we've seen in many newspapers across the country about federal reports on stent procedures that's finding potential fraud, or federal investigators supervising stent doctors of all things, or audits finding that medically unnecessary stents have been placed.
Okay, so this is disturbing and serious. I think it's pretty clear, though, that fraud cases clearly are a few bad apples. I mean, we know that's a small amount, although I suspect that is a reason that we need to measure it. If we don't measure it, we don't know it, and we can't prove that it's just a bunch of, wild accusations, right?
Right, well, you know, I know that these are isolated cases, but have you ever watched Dr. Oz?
Oh, I love Dr. Oz. I watch it all the
Awesome.
time.
I know you have a lot of free time in the middle of the day.
I have a lot of free time in the middle of the day.
Do you know what Dr. Oz said?
No?
Dr. Oz said that 53% of PCIs performed in the United States are inappropriate, out of nowhere. Don't know where he got the information, but that's what was on his show, the one that you obviously weren't watching.
I'm not going to watch Dr. Oz anymore. I'm going to switch to The View.
Yeah. Sound like Whoopi Goldberg and Barbara Walters on the same
yeah.
stage.
I don't know.
That's
That's terrific.
know.
All right, what else do we need to know?
Well, I can just tell you, if you've been reading Bloomberg lately, you also know that there's been other wild accusations about inappropriate stenting. You know, this came out just in the last few weeks. The headline is "Deaths Linked to Cardiac Stents Rise as Overuse."
What data was it based on?
None.
No data.
No data. I mean, just basically this speculation about deaths and overuse of stenting without really any data to support it. So it's important. This is an important public perception.
Okay, so we need to measure appropriateness, but Fred, does it have to be us? I mean, I work for the government. Can the government do this for us?
Well,
Okay, never mind.
okay.
We better move on. So the fact is, the why is that we need to do this. It's our professional responsibility. It's a commitment to value and patient-centered care, and we can do it better than anyone else, or we should be able to do it better than anyone else. But that really begs what we need to do and how we do it. So, Fred, how do we do this?
Well, it is kind of complicated, I'll concede, but really this is when we get to the appropriate use criteria, which are intended to define when and how to do a given procedure in the context of scientific evidence, the healthcare environment, the patient's profile, and the clinician's judgment. That's what it's all about.
Okay, so appropriate use criteria then, I think an important question becomes, aren't they just another performance measure?
No, John, AUC don't taste just like chicken.
Like chicken.
Yeah.
Hey, Fred, did you know that rat tastes more like chicken than emu? Don't answer that.
Okay, I'll stay away from it.
So,
But to the bottom line,
what is the bottom one? KFC.
that's KFC at the bottom, whatever. They're not sponsoring this. Okay, so.
All right, so where, I'm just glad you didn't ask for some emu.
Yeah. Although that would be kind of cool. Hey, Julie, any emu? No, I guess not. Keep going.
All right, so where do they fit? Where do appropriate use criteria fit in the tools of quality if they're not performance measures?
Right, so like performance measures, AUC are based on evidence and guidelines.
Okay.
That's what they have in common. But unlike performance measures, now performance measures are the kind of things that you really are supposed to have to do.
You have to do them. They're black and white. They are the things you're supposed to do unless you provide a distinct reason not to.
Right, so aspirin for a heart attack or an ACE inhibitor for someone with left ventricular systolic dysfunction, those things we're really supposed to do. The AUC, again, they're evidence-based, but they're designed to provide the clinical scenarios that you might see a patient in and help you determine whether or not it's appropriate or not to do a PCI, in this example, for this patient. And like the performance measures, they're multi-societal, and as I said, evidence-based, and so they provide us a basis, again, for taking care of patients with common clinical scenarios.
Okay, so the AUC take common clinical scenarios from the guidelines, correct?
Correct.
And they're endorsed in the same way as the guidelines and performance measures are by multiple societies.
Correct.
And that explains why they've said it's an effort to insert clinical rationality into the appropriateness measurement, as opposed to, for example, trying to measure appropriateness using like insurance claims.
Exactly.
Okay, now the only thing is the clinical scenarios. I mean, there could literally be millions because every patient may have a different clinical scenario. And you hear a lot of questions about how do we deal with the all potential clinical scenarios.
That's exactly right. But you know, John, what the AUC do is they don't focus on what I would call the rainbow Zebracorns, the kind of unusual clinical cases that we're all going to see every once in a while in practice. I mean, the bottom line is the AUC are designed to capture the most common clinical scenarios, and at the end of the day, they cover most of the patients that we're going to see in everyday practice. Are you eating that pie, by the way?
Nope. You feel
That's
free.
okay.
Okay. All right, so I think I'm getting the hang of this. So if I've followed you up till here, we need to measure it. The why is clear, and it is a tool of quality, and that sounds like something that NCDR can do. So if I'm following you correctly, NCDR then takes the AUC, the guideline-based, evidence-based AUC, and we put them in to measure in our programs, and we provide feedback with benchmarking so that individual sites can see where they are in their mix of appropriate, inappropriate procedures, and then they should be able to use the dashboards to drill down on where, including the physician report dashboard, to be able to drill down on individual cases and see where they are on PCI. How am I doing?
That's pretty good. That's easy for you to say, but that's essentially it. You know, one of the other issues that's come up, though, is the issue of data quality and how that plays into things, because obviously the measures are only good as the data that comes out of it.
And how good is the data?
Turns out the data are excellent. Thanks to everyone around this room, the data from NCDR are considered to be the top of the line, high quality data in observational context. It's been noted not just in NCDR, but elsewhere.
That's great. Well, I also think there's a lot of focus not on data quality overall, but on the actual PCI inappropriate cases. And correct me if I'm wrong, Fred, but there has been some internal validation done where NCDR looked at 127 or so of the inappropriate PCIs from 11 sites, and were able to show there was 100% concordance in the appropriateness assignments, both by the algorithm and by the accuracy of the data that was entered by the site. And in fact, they then asked the sites of these 11, did they want to take back any of the inappropriate cases and reclassify them? And if I remember the numbers correctly, only 8 of the 127 cases were any questions raised. And even the questions raised were kind of interesting. Site 1 said they had documentation mistakes, not data entry mistakes to NCDR. Site 2 changed 2 cases to increase the angina class of the patient after further chart review to make them appropriate. And Site 3 said they simply didn't believe their nuclear cardiology or interpretations.
Huh, okay. What do you know?
All right, so it looks like we can and should measure it in NCDR, and it looks like we can do this validly. If we're doing this site by site, can't we also learn about how PCI is being delivered in the United States as a whole?
I'm glad you asked. There's a paper that came out in JAMA in just 2011 that looked at the appropriate use criteria in more than 500,000 PCIs in more than 1,000 hospitals, many of whom are represented here. And you know what they found, John, in terms of the overall proportion of inappropriate PCIs?
The overall proportion, the overall percentage of inappropriate PCIs, well, I assume it's 53%, because that's what Dr. Oz said.
He's always right.
Yeah.
Well, actually, he was wrong this one time. It was 4%. 4% of overall PCIs were considered inappropriate. And the fact of the matter was, even if you take out urgent PCIs, PCIs for MI, the acute PCIs, where they're typically almost always appropriate, 12% of elective PCIs were inappropriate according to the AUC, according to a standardized method of assessing this issue.
And am I correct, Fred, that compared to almost any other medical technology or imaging study that's ever been published, these rates are actually significantly lower, like better, much less inappropriate?
They are better.
Well, I know bad press gets all the press, but it's too bad that this didn't get more positive press. I would say, though, that here's an example from a patient site, a patient-facing site. It's largely used by patients who have had angioplasty, called angioplasty.org. It's actually a very good site. A lot of patients participate in it. And when this study came out, this was their coverage of the study. A major study refutes 2 major myths about angioplasty and stent use in this country. Myth 1, that angioplasty is vastly overused and unnecessary in most cases. And myth number 2, that angioplasty is used mostly in stable patients or elective, as opposed to those who would benefit from acute PCI to reduce death or heart attack.
That's exactly right. Maybe I'll start reading angioplasty.org instead of watching Dr. Oz.
Yeah, I think that's a good idea. So, Fred, why don't we just declare victory here then? If we measured it, and we measured it accurately, and it looks like we had pretty low rates of inappropriate, do we have any issues?
Well, it gets back to variation, John, because in the same paper by Paul Chan and colleagues, as you can see, you know, a number of sites had inappropriate rates of less than 10%. And so the bottom line is no one really expects this to be 0. There are going to be those rainbow Zebracorns and other cases where they're going to fall out of the
And they're not performance measures.
And they're not performance measures. So we're not looking at a 0% rate here.
Okay.
But let me bring your attention to the right tail of this distribution here, where we're seeing substantial numbers of hospitals where 1 of 4, 1 of 3, or even 1 of 2 patients getting a PCI is deemed to be having an inappropriate PCI performed.
Okay, so this is actually pretty compelling evidence that we need to measure it, we need to feed it back, and we need to promote quality improvement. Now, how do you know, though, that there is the need to promote quality improvement as opposed to just pure documentation? I mean, how do you know that this isn't just because it's so difficult to document around elective PCIs?
Well, it turns out, John, that the documentation requirements are an incredibly low bar. Like, you might even be able to clear that one. Not sure.
I don't know.
But when it comes right down to it, you're really being asked in the context of elective PCI to document 3 things. The first is what's the result of the non-invasive test?
Okay.
The second is, what are the patient's symptoms and what medications are they on when they have those symptoms? And then finally, what are the results of the angiogram, which you have right in front of you when you're doing the study? So to be honest, it's not asking a lot to document all of these things.
Okay, well, it does seem pretty reasonable to me that if you're going to do a procedure on a patient, that you would document their stress test, their symptoms, and what meds they're on to justify the indication for the procedure. But I know, I hope they're rare, but I suspect some interventional cardiologists may still push back and say, that still is a lot of work. It's still, you're asking a lot of me to document this for something that's really a minor procedure.
Well, a few interventionalists might look at PCI as a minor procedure, but the bottom line is that's not the way patients or their families look at it. And I think it's the least we owe them to at least document the reason why we're performing an invasive procedure with important complications that costs a lot of money.
I think that is fair, but maybe the other thing they might raise, that's right. I think the other thing they might raise, though, is that they feel like they're being watched for everything. They feel like they're being measured for everything. Now they have to document everything, and they just feel like it's as though they're being watched everywhere they go.
Right, well, it turns out, John, we are, I'm the most interesting man in the world.
Yes, you are.
We are being watched for a lot of things. We're even being watched for hand washing. I don't know if you knew it, but when we're on rounds, and hopefully not in the washroom, we're being watched for hand washing. So the bottom line is we are being watched for a lot of things. This is an era of accountability, and we have to be acknowledging that.
Fair enough. So I know that it is true that states and payers are moving forward with appropriateness measurement with or without us. And there are some states that are doing it with us. For example, Wisconsin is adopting the NCDR criteria, working with payers in the state and trying to have a nice rational discussion about how to use those to promote quality improvement and not in a penalized or a punitive way. I know there are other scary things out there though too, right, Fred? There's the New York thing with the Medicaid is considering using some form of AUC to deny payment for inappropriate PCIs, and it seems to me that this really is a time where we need to measure it and then use our information to advocate with Medicare, the other payers, and with our other partnering societies, correct?
I agree completely, John, because the bottom line is there are some storm clouds gathering around this issue, but I think we really need to stay on the road and be focused on this issue of doing it as well as we can, because we know we can do it as a group better than anyone else can using the clinical data in the registries. Okay, absolutely correct. All right, so we do need to tackle this though. Another criticism raised about the AUC is, are they going to be nimble? Are they going to react as clinical care changes, as new evidence comes along? And also, I think there's been real concerns expressed that the terminology used, even though it went back to the original RAND terminology from many years ago, such as inappropriate, has been misinterpreted by some external bodies, some payers and others, as saying that it's an absolute. So if a case came out that way, that payment should be denied. And so is it true that there's evolving criteria and terminology coming? Absolutely. So the first thing is that just like the performance measures, the AUC evolve in response to changes in the guidelines and changes in the evidence. That's an important point. The other thing to know is that, in fact, this is an iterative process, and as the result of some of these concerns, the terminology is going to be changing in the registries, where instead of having uncertain procedures, these are procedures that may be appropriate, and instead of procedures being considered as black and white inappropriate, they're deemed rarely appropriate. And this terminology will be appearing in the new summaries with the evolution of the registries. Okay, great. So last but not least, I've been pushing a little bit in this discussion for all the downsides, but isn't it true that there are some really forward-thinking hospitals, practices, clinicians, and care teams that are really taking on measuring AUC and doing it actually as part of care delivery, like actually having it inform their care decisions while they're documenting? Yeah, here's an example here, and I understand there was another example from a colleague in North Carolina is doing the same thing, integrating the AUC into the stream of workflow, where in this case, this is an example from Prairie Cardiovascular, where you can see they have a scenario. They say, is it an urgent case or is it a stable case? What are the results of non-invasive testing? Is the patient on medical therapy? What are their symptoms? And that sort of helps them guide the appropriateness of a PCI before they send a patient to the lab.
And a lot of these things are becoming widely available, right? So there's Health Outcome Sciences has an AUC calculator along with their other decision support tools, and SCAI has a free online appropriate use calculator. And if I'm not mistaken, Fred, there's an app for that now. There's a free ICATH app developed by some junior faculty and a fellow at, I believe, at the Oklahoma City VA of all places, and you can get that free in the App Store. Do you know what an App Store is, Fred?
What's that? I'm sorry, I got to adjust my trifocals again, I guess.
Yeah.
But
all right, Fred, let's take this home. What's the bottom line?
so the bottom line is, John, we all have a professional role and responsibility around understanding appropriateness for patients with cardiovascular disease. It's important for us to understand the AUC are not performance measures, but they are important quality measures that get at this issue of value in care. And it turns out that despite what Dr. Oz says, and despite what Bloomberg says, most PCI procedures are appropriate, but we still have room for improvement because there's a lot of variation. And all you need to do is document symptoms, stress test results, and the results of the angiogram. You need to know and participate in your NCDR data. Focus on ways of integrating AUC into practical workflow, and then, again, work on advocacy through professional societies to make the AUC as good as they can be.
And used responsibly.
And used responsibly. And so as Schopenhauer says, and I'm not exactly sure why he looks so angry, but Schopenhauer said that all truth passes through 3 stages. First, it's ridiculed. Second, it's violently opposed. And third is that it's now accepted as being self-evident. And I believe that that's where we are today with the AUC. It's become an issue that is now self-evident, something that we need to be doing.
I 100% agree. I will only say, though, that I know there will still be resistance. People will leave, you'll go back, and you're going to get some resistance. But the only thing I would say is we can't give up. This is doing the right thing, and we should push hard. And it may be a little like the diplomat Robert Strauss said in the Cold War when with reference to the Russians. It's like wrestling a gorilla. You don't quit when you're tired. You quit when the gorilla is tired.
You know, John, that's right. You know what all this wrestling has done? It's made me thirsty
For what?
an adult beverage.
Oh, thank you.
Yeah.
Perfect.
Stay here. Stay here.
Cheers. Well, Fred, cheers.
Here.
Fred, I wish you well on that talk whenever you're giving it.
Thanks. I hope it goes okay.
Yeah.
Hey, John, I forgot one thing.
One thing, really?
One thing. What's that? I'm sorry. It just occurred to me that today is a very, very special day.
Oh.
And not just because we gave a talk on appropriateness. Special indeed. It's because it's Julie Coy's birthday today.
Oh.
So maybe what we could do to thank Julie for all that she's done and to congratulate her for her birthday is to sing happy birthday to her.
On 3.
On 3, and I'm going to take off my microphone. Thank you. That's right. Applaud for that.
That's called
right?
quality improvement.
Okay. So, happy birthday to you. Happy birthday to you. Happy birthday, dear Julie. Happy birthday to you. Thank you. Thank you all. Thanks for coming to the meeting.
I'm not even taking the...
They're terrific. Thank you.
Thank you very much.
You're welcome. Notice I only brought the beer.
I know. You guys were wishing I'm saying there's a cooler outside for everyone as you leave, right? Pat Casey told me I wasn't allowed, but I would have done it. Hey, I am in charge. I should get a grip. Well, thank you so much, Dr. Rumsfeld and Dr. Masoudi, and it's kind of weird calling you doctors after you get up here and you act so crazy, but somehow you're able to weave humor into something that is so critical and important to things that we're all dealing with right now. So thank you very much for everything that you did to put that talk together. I also wanted to thank the 120 plus members, physicians, nurses, administrators who are so involved with the NCDR. I mean, literally 120 plus and probably even more than that. And also to our planning committee who put together the design of the curriculum, but then there are also all these work group committees too that made the workout sessions for you, which included many of those of you that are in the room right now. So thanks to all of you too. I think the overwhelming input into this program shows. So many people have stopped me saying, you know, you're really giving me what I want, and then creating new ideas for the next year. So make sure with your evaluations that you complete and submit before my birthday on May 23rd, that you don't forget that, my birthday, May 23rd, right. That's right. Also to our faculty who spent countless hours of putting their talks together. It's you guys, any of you who haven't spoken, if you have interest in perhaps trying next year, reach out to us. Pat is wonderful. She's an educator by training, nurse educator. She'd be more than happy to give some guidance and support to help create a new generation of speakers as well. I also want to thank all of our exhibitors for being here today. They were overwhelmed by the interest and curiosity and looking forward to next year. And is Pat and Julie, and not Julie, but Barb, if you can come down. I wanted to thank you, and I don't know, Pat with the big hat. She's been working like mad, and she's sick. If you didn't know, she's just been horribly sick. This is Barb Christensen, sort of an unsung hero, because I get the pleasure of sitting up here all day, night and day. But really, Barb is the one who works with Pat. She oversees all the registry managers, and she's the brains behind everything that goes into supporting you all, with Ken Hulskamp, who manages his team, and Calvin, who are at the reg desk. So Barb, thanks so much for everything that you do. And you know, lastly, about you all, about us. I think at the end of this kind of conference, it's like so much has been absorbed. But the goal here, I think, is to realize that you all are the rumble. You're the rumble back in your hospitals, back in your communities, that are literally shifting the ground for the next day of what healthcare is going to look like. As you can see, the world is following the work that you all are doing. You're rumbling, capturing this clinical information so that it's being used in more important ways than I think any of us, no, I think we absolutely imagined it. Because there was a day where there were people who tried to close the NCDR down. So this is a waste of time. This costs too much money. Nobody's ever going to buy into this system. Are you crazy? And there are people that are in this room who were a part of that day, and they said, no, are you crazy? No, we have to do this. This is the right thing to do. And they fought. They were disruptive innovators. They stuck out, were out of the crowd. And as a result, I think it probably paid off, and it's got to be very satisfying to everybody who was involved with those times to see what we've become and what we still will continue to be. So as we all prepare to leave, I just hope that you leave with a whole new, fresh view on your role. I hope if you don't walk out of here realizing how important your job is, and if your hospital or your practice doesn't realize it, you should be charged with some new information that's probably going to get their attention in a very big way. And I hope that you all will plan to come back for next year, because I can guarantee you there's going to be a lot that's going to be happening between today and between 12 months from now. And like Dr. Harlan Krumholtz said when we started off this meeting, he says, we can do it. We are the disruptive innovators. And we are not going to be the ones who look backwards saying, I wish I had started that 12 months ago. So on your way home, after you've had a chance to download, think about what is it that you're going to do between today and 12 months from now. And be thinking about your posters, be thinking about your projects. And I'm really excited to see what the news is going to be in 12 months from now. You guys have been fantastic. Another wonderful year. And have a safe treasure on your way home. Travel on your way home. Yep, see you in San Diego.